Hello, everyone, and welcome back to the Resilient Aging Unfiltered podcast. We have an amazing guest today, a friend and colleague for years now, Monika Wuk. I don't think I've ever said your last name correctly until you sent me the phonetic spelling. So thank you, Lukasiewicz.
Nailed it.
Amazing, exceptional occupational therapist with special expertise in working with older adults, especially those who have Alzheimer's and related diseases and progressive cognitive and functional impairment, amongst many other skills and talents, I'm sure some of which I don't even know about. So maybe, Monika, you can tell us more about you that you want to share here on this podcast and what got you into this field of occupational therapy, specifically working with older adults.
Well, thank you so much, Dr. Cabral, for even having me here. I've admired your work for a long time. So it's really an honor to get to be here and in unfiltered conversations. So thank you for the work that you're doing in the world. I got into occupational therapy through a personality test. So it was actually kind of my second go around in college. The first one, I didn't know what I would be doing with that initial degree. So I took a personality test and it matched me up with OT. Fast forward into how I got into dementia focused care. And I guess before I say that, I will share that a detail that immediately drew me into occupational therapy. And I'll share this with the understanding that I'm sure some of the listeners who might be tuning in have never heard of occupational therapy, or some perhaps have heard of it, but they're like, I don't exactly understand it. Uh, so the thing that drew me in immediately was the description of it as both a science and an art. And when I saw that description, I was immediately intrigued. So if you fast forward into my career and how a holistic healthcare profession ended up putting me into dementia care, or a focus on that, for me, it really started in home health. So I've been an occupational therapist for about 15 years. I've studied different things from lifestyle redesign with USC, coaching, motivational interviewing, and I was really loving home health, home-based care, because I was really seeing how people interact in their environment with their people, with the struggles of their lives and their health conditions. And one of the things that really became frustrating was the impact of cognition in people's daily lives and how much I could really begin to see it in home-based care. And when I say see it, it was actually quite invisible to most traditional healthcare teams at the time, because this is about 2013, I think, that it started dawning on me that it was like, oh my gosh, part of the reason that there's repeat falls or like trouble with medications is that they need more cognitive assistance, but no one's like finding that, if you will.
Hmm.
I think the first thing that tipped me off into this field was actually a research article about the importance of occupational therapist screening for cognitive impairment. The particular study talked about the short blessed test. So that was the first one that I started using. And they started talking about how occupational therapists are so well positioned to kind of capture this space of function, if you will, and to, we're not diagnosing anything, but we're in a great position to catch something and then to offer it back to the referring provider to say, can you please look a little deeper at this? So kind of fast forwarding a little bit, I was put in contact with a mentor, or she became my first mentor. Her name is Mary Platt. She was trained in a model called the Allen Cognitive Model, or the Allen Cognitive Disabilities Model. That blew open a whole bunch of new ideas for me. Kept loving home-based care, did home-based care through COVID, and then in the midst of just one of those moments as a healthcare provider where you're like, do I stay in this like healthy tension of doing really meaningful work but being exhausted, especially through COVID, or do I just like leave? Those moments where if it's an unfiltered podcast, that was the truth of it. Someone turned me on to the Skills to Care program, which is an evidence-based program. I took it through Rachel Wiley, tremendous for her as my next kind of mentor. And then from these evidence-based trainings, I just began to notice my own practice come alive at a new level, noticed results with care partners and people living with dementia in a new way. and then eventually attracted another position that allowed me to work inside a federal grant and learn the COPE program through Drexel University and Dr. Laura Gitlin. COPE stands for Care of Older People in Their Environment. And just had the opportunity to work with a wonderful group of people at Oakwood Creative Care in a community-based setting, but also really bringing to the community the COPE program in a way that it can keep going in primarily an insurance-based model. And now my passion is really with how do we keep this need for this, especially like evidence-inspired work, occupational therapy, how do we keep it growing and like weaving into the systems
Yeah.
at a time when it's like the systems, I feel like healthy tension, I guess, is
That's a nice reframe. But thank you. Wow. Thank you for all of that. And you've had such a journey career wise, it sounds like. And so at the beginning you mentioned, I just want to circle back. So that science and art, right? That's what you said. And I always think of architects as another career. Um, and architects are more well understood universally what they do. And occupational therapists are not, but architects are crucial to so many aspects of our lives. And it's such a disservice to all of us that are a loss that we can't capture and utilize and compensate or value occupational therapy, or we'll say OT moving forward, for what you do. And I love that. It's such a, of course, touches my heart that we are passionate about working with the same population and get excited about that. And a lot of people don't, or young people, trainees, like aren't exposed to that. But talk about challenging what you have, you know, been drawn to for your career. And just want to acknowledge and honor that. That's so amazing. And I'm so excited to keep working with you and figure out how to incorporate this, get more uptake and
Hmm.
in the healthcare system, especially with this population. But
Thank you.
did we yet really define occupational therapy in terms of, because I would love to, if you could elaborate on that.
Yeah, well, and I'll share with the listeners too, like a little bit prior to the call, you and I were laughing a little bit about, what if there could be a new tagline for occupational therapy, what would that be? And I was mentioning that I've been thinking about that for at least a couple days now. And ultimately, there's different ways that OT is defined. Some people may say that it's helping people get back to doing the things that they need to do or want to do that's been interrupted because of an illness or injury. Think of a quick tagline for it. What comes to mind is helping you get back to your season of life, whatever that means. So like, that's the shortest tagline I can think of. I used to work for Cutco. Have you heard of Cutco
Yeah,
knives?
of
Yeah.
course. Yeah.
So, like, I think I was a junior in high school. It makes no sense how this even happened. I look back and I'm like, why was I a junior in high school selling Cutco? But the thing about Cutco knives is like, if you've used one, like what sells Cutco knives is like you have someone try it, right? You're like, cut the rope, cut the penny. And so much of occupational therapy, I think, is like that sometimes we can try to explain these different aspects, but it's almost like put us in, coach, and we'll like
Yeah.
show you what you can do. So I don't know if that, tagline helps at all, but like how does that sit with you? Does that sit a little more clearly, or do you think a lot of your clients would still be like, so say more?
I like that you're thinking of this, because I don't see that well, you would know much better than I do what's happening in terms of payers and Medicare, like trying to find ways to value and reimburse your services for different populations, and how to do that and how to sell that, because you have all this evidence and you just talked about some with the COPE program and other things. So I like that you're working on it. I'm gonna try to help with that too, because that's crucial. But getting also to your point of, it's about taking action. And I know I in Brain Love, that's such a core part of the philosophy. Knowledge only gets you so far, and really only a small part of the way unless you implement it. So you're really helping people to implement it exactly in their own way. This mention at the beginning of medication, maybe it's mismanagement or who knows, that's so important. And I believe that if we had a way to do a large scale trial where we monitored people and half the group, we say had automated pill dispensers and someone monitoring them taking, or they had to do a video of themselves every day and submit it, they'd suddenly feel so much better because they're taking them correctly. Or you might find this person is on way too many medications that they don't even need when they actually take them. So you're going in there and figuring that out and addressing that. And that saves lives for sure. So I love
Oh my
it.
gosh. And that's one of the things that I think is so profound, especially about the home-based care, is the putting the pieces together. And I'm also realizing in that particular tagline of OT that like the heart of me, and especially after practicing for 15 years, my tagline is inspired by what I see and experience from my own eyes. And my favorite place to practice, I mean, it's beginning to be at a system level, but ultimately nothing feeds my heart like being with the person living with dementia and the care partner. But what I'm realizing as we talk about this is it's almost like the taglines you need for different systems, because it's almost, probably a tagline of like helping people stay out of the hospital,
Yeah.
that it's like,
Depending what the need is.
yes,
Set your main objective when you do the evaluation for individuals, and yeah, so you can give each family their tagline, their goal. I'm sure that's what you do.
and even healthcare systems,
Yeah.
right?
Okay.
I think even leaning into systems, there's room for so much innovation with the complexities because, like you said, this is such a complex area of practice that some of my favorite conversations are the ones that it's like, can we talk about the hardest client? Like, which one is not causing, which one is like showing the most challenging behaviors that's disrupting whatever it might be, whether it's quality of life for the person living with dementia or the care partner. So many rabbit holes to go down.
Yeah. A million. So let's go down one. Can you share an example of a success story with this group of people?
Yeah. I was reflecting kind of on that particular topic or just like on the different families that I've worked with. And I just have such appreciation to them and all the folks who've ever even just kind of like trusted occupational therapy to work with these families. But the main one that came to mind is a husband and wife. The wife had Alzheimer's. They were I believe they were both in their second marriage. So they hadn't been married more than I think 15 years. Newly moved to Arizona, really fresh in community with the move back. And part of the reason that occupational therapy had been asked to come in was because he was feeling so much stress and not knowing how to help her through activities of daily living, through the repetition in the communication. She was not bathing as much either. And he was really, I will never forget the look of exhaustion, sincere exhaustion, and like sincere care on his face. Like he wanted to I could see like curiosity, like that sincere curiosity, but just like defeat. But I remember just a couple specific things in going into their house. Number one was the very first visit. Something that I love about especially these evidence-based programs of skills to care cope is they're encouraging OT to really at least be in the house for at least one, if not two sessions, so you can really see the environment and have those interactions with the family. And I remember it was the first time I had to be super mindful of not creating a sense of like jealousy in his wife because I could sense that she was kind of immediately taken back that there was like another woman in the house, if you will. And so I remember that the challenge of building rapport with them and how important that was that she knew that I was a presence that could be trusted and was like on her team. Something that was interesting was even just trying to position myself. So when she was coming in the room, she was able to kind of see him first, not me, because I even started to notice when she came in and saw me first, she would become suspicious. And kind of fast forwarding into some of the things that ended up being really, really special about working with this couple. One was the demonstration that could be done in communicating with her. So he could watch me communicate with her in ways that did not create more tension, that could direct her forward towards whether it was an activity or like eating. So there was a really special element and a very intentional element of demonstration that took the pressure off of him that he could kind of watch it happening. The other thing that was really powerful in this particular instance was being able to work with him one-on-one. So I always collect the information, like with both parties. But then there are some sessions where it's just better to work with him one-on-one. And I remember really helping him understand the strategies that were working and the strategies that were not working, but also why. Some of the wins, being even environmental wins. So, for example, one of the things that was an initial challenge was showering. And I remember that he was like, well, she's used to using this tub shower, but I'm used to using this walk-in shower. So he's like, I just take her with me into this walk-in shower. Traditionally, you may think like, well, where's there any problem in that? But in this particular case, I remember that he's already telling me she's resistant to getting into this, what's a physically more safe looking shower with him because it's not familiar to her. She's used to a different kind of routine habit with this other shower. So, with the use of a shower chair and teaching him how to set up the environment, she was able to return to showering with almost no problem. And it was truly a matter of shifting the approach to showering and the environment, but even in getting a shower chair, right? So it wasn't the element of safety wasn't an issue of like standing. And that particular environment also had grab bars in it where the other step in shower did not. So that was an immediate win for him. Something else that was really, really crucial, I think, was validation, just really being able to help people feel seen with where they are and recognize like, this is hard, this is still complicated, and you're doing a really wonderful job. And I try not to say just that general statement because sometimes I'm like, "Mm, what does that even mean?
Yeah.
You tell everybody that.
Yes.
But of being like, I see how you're caring, I see what you're noticing. These are helpful things to notice. And also empowering him that, like, you must take care of yourself. So referrals were really helpful for him. She ended up getting into a day club, which meant he had like a couple hours to breathe. But something else that was unique about them too was helping him realize her strengths, because I think it's tempting for most people to kind of get caught in that, like, well, she's not doing this. This is different. This is kind of a little bit annoying. But with her, it was like he began to see she has this strength, like physically, she's strong and can get herself up and move. She loves bright colors. So, how do we like incorporate that more? Follow single step instructions, and also she loved afternoon drives. So, like, helping him see these things she liked that were calming for her too, that he could put into his, overall routine was really special. She's no longer with us, but he, like, specifically came back to share about the impact that this program and OT had had for both of them. So that's probably the one that, like, comes to mind the quickest. I will say, Dr. Cabral, that I've been surprised for how many times occupational therapy was really well positioned, because we typically are screening families to be like, what's going on? But way more than I had expected, hospice was appropriate and the most appropriate referral. And that shocked me that we being like a system could so easily be missing this like precious window of time that when some folks are thinking it might be time for therapy, it's like, I'm happy to come in and work with hospice. It was really humbling to just recognize the value of being a timely referral too for those services.
Wow. Thank you. And
Yeah.
it's amazing you remember all those details, firstly. Um, there you brought up so many things, and every single one of them is powerful. And I think about it might not, some listeners might not realize the huge significant impact made when their spouse has been refusing to take a shower and now they're willing to do that. That's immense, that alone, on top of all the other things that so a couple, yeah, like I could jump on a number of things with questions. It sounds like he was at the right in the right space. It was the right timing for you to be there to hear these things and to act on them. And maybe partly because he was so just burnt out. But I wonder your thoughts on that with in general, the
Readiness.
factors that lead to care partners taking your advice up more readily.
Yeah, such a intersection point that I think is often overlooked. One thing that I will say that was absolutely a crucial part of making my collaborations with families so helpful was the evidence-based approach of matching whatever I was about to say or do to the level of readiness of that care partner to change. And so what I like is that, in both of the programs that I leaned on the most, and Skills to Care and Cope have a tremendous amount of similarities. But I'm able those both of those programs gave me permission that no matter where someone was, I could meet them where they were at. So let's say, for example, low levels of readiness to change. Someone is like, well, what is dementia? Maybe they don't even have a diagnosis, but they know things are going on in the house. I can empower them to potentially get a diagnosis or at least start reading about it. With him, he really was in such a hungry state to learn. So that absolutely makes for way more. The first word that comes to mind is satisfying of experiences for me, which is not at all what it's about. But there truly is a trajectory of change where people are willingness, you say move the rug and they're like, great, it's gone, versus people being like that one, like we got that one in Europe and it's going to stay,
Yeah.
you know. So, but I think, so there really was an element of me being willing, the provider being willing to be like, you're here, I need to come here too. Like if you're on FM 98.1, like I need to come be on FM 98.1 too. Otherwise, our time is going to be, we're going to miss each other. So I can really appreciate that you honed into that, because that probably is one of the most powerful aspects, principles, frameworks of these evidence-based programs that for me brought profound results in watching them change and
Mhm.
watching people also go from kind of being stuck and resistant to at least becoming curious to try, especially strategies. That's what it was a lot of times, is helping people realize that thing that you just saw me do, that's a strategy. That thing that you realized that didn't work, that's a strategy that's not working.
That's a bad strategy. Yeah. I know you don't say that like that. Um, wow. You're really a genius. I mean, seriously, and you're saving again, like I go back to how many healthcare dollars you're saving by the things that are avoided, that people don't end up having to, they don't have a fall. They don't have all of these other things. They don't take in the wrong medication. They're staying hydrated. Their care partner is staying healthy because they now have tools and resources. And so, but it's so hard to prove, it can be hard to prove this to the degree and that it does have positive impact. And I mean, same, in some ways for me, but I think more so for you, and all the joy and satisfaction that you do hear experience from patients and families. I'm sure, I imagine at times it's also um, leveled by the many times that people aren't getting it, and you're putting in so much effort and heart, and not just the families, and patients, but also healthcare professionals. So I just wanted to acknowledge that.
Thank you. I certainly have been discerning more too, and I'm sure you can relate to this, is like as a healthcare professional with a heart of an innovator, it's like how do we meet each other, whoever that is, each other, right? With compassion, but also this like we can do better. Like how do we do better together and kind of break molds? Not for all the right reasons though, with respect to like the chaos that can create and being like, this isn't working. And how do I either step back to come back from a new perspective or to be like, I have led the horse to the water type of thing.
Yeah.
It's complicated. I can appreciate that validation for sure.
Yeah, and I think about, so when you said innovator, and I think of visionary, like you have to be able to envision what's possible, what doesn't yet exist for individuals and families and systems. And I think OT is especially good at that. And that's probably what draws individuals into those careers. Yet, vision doesn't always pay the bills. Having vision, so that's a challenge. But
True.
I wonder if, and then I think about seeing the possibilities and potential in individuals and families. And you talk about strengths based, or, I think of like possibility focused approaches. Is that what OT is? Are all occupational therapists like that?
I would say ideally, yes, because it really is about matching, having an individualized approach for any single person, whether it's a person, a community, or a group that you're working with. Typically, any occupational therapist is first going to do the assessment of like, what are the abilities, what are the challenges, and then link whatever the goals are to that kind of match of barriers and opportunities. So I would say yes, any occupational therapist that's been well trained is going to look at the strengths and how to, because from there there's so much potential and or truth to be told. And I feel like in dementia care there is an element of humility and just like it is the final chapter, right? So like I'm a perpetual optimist and it's been really humbling to honor the last chapter of life as something that is not a failure, because like in a pretty progressive world, it's almost like the final chapter can be seen as that way. But I'm grateful to be around people and kind of finding more conversations where people are dignifying like the chapter, whatever chapter, right?
Yeah, definitely. How do you bring or do you bring the topic of resilience into your work?
More through a lack of words and more through action. For those who are ready for it, I find, um, especially in some of the evidence-based programs, and I will say in both of these programs, they're primarily designed to serve people who are really wanting to stay in the home. And that type of duo, if you will, or like village, depending on the situation, I think they tend to be a bit more tuned into resilience because it is going to take more to be, to keep things moving smoothly at home versus a relocation. No judgment on either one. Everybody needs something different. But I do find that I speak less using the word resilience, but always with a mindfulness of the importance of it, especially for that care partner. Who often does not even like realize what respite is or how important it is. It tends to need validation of just I don't even think they realize they need validation, but it's like I feel like it's blowing on an ember that's going out, and you're just like, "You're doing it. You're doing the right stuff. This is still hard," you
So,
know?
yeah. Um, I just recently interviewed Rick D'Amico, and he analogized being a care partner to being like a pro athlete. And it's just like constantly working hard, training, like you're all in.
It's such a beautiful analogy and so empowering too of like, this is a strength. This is a highly, specialized
Mm,
and the need for recovery too even.
yeah. Yeah.
Yeah.
I'd love to ask about you talked a lot about working with individuals who maybe are in those moderate to severe stages of functional impairment and their families. Is there a role for you in occupational therapy in individuals who are only experiencing the earlier stages, like mild cognitive impairment, where they're still functioning independently or just needing a little bit of help?
Good question. So I'll say from experience, I'm most experienced in working with those who are in the early stages to borderline end stages. And I really do think there's room for the role of OT. I know some OTs who have done different programs, especially designed to serve in those stages. And I think what it makes me curious about is where the opportunity or where the impairment and occupation is in those stages. And I kind of wonder what the menu of goals or topics might be, because in COPE, there's a more or less kind of a menu of topics based off of research that like most care partners probably gonna pick one from this list. It makes me curious to know what the difference would be in the list, especially occupation-wise, and maybe also the difference in referrals that would be activated at that point. I think there's definitely room for it and room for a lot more innovation there to to better serve folks. I think it helps. I mean, and that could be an interesting student project too, even
Yeah,
on the
that makes sense. I think about what would be most helpful for those individuals. And lately, I've been thinking more about recreational therapy. And just in general, I think about that for when anyone retires, like
yes.
a retirement coach that had, your skills and or recreational therapy to like get them on track for what do they want,
Yes.
evaluate their lives, what they want for the rest of their lives, regardless of if they have Alzheimer's disease or their thinking is fine, right? So that's a whole other question, and that's not going to be covered by health insurance, I'm sure.
I wish.
So I wanted to, is there anything else that you wanted to share about working in this field and what you think people should know? It's so open because I have another question I wanted to ask after that on a different topic.
I will say that the influence of the evidence-based programs of skills to care and especially COPE, TAP is another of a kind of the same family, the tailored activity program. Those programs had a profound influence on me as a clinician. So I hope, if clinicians are listening that you, whatever field you're in, you really look at what opportunities for evidence-based programs there may be to really just boost your skill set. The unique thing I'll say about that is that until I had studied those programs, I did not have the confidence nor skills to really come in between the dyad. And so until that point, I was just kind of left being like, how do I rehab the person living with dementia? Or can I not at all? And it was kind of this like either or was just like, leave the person in dementia in this room, talk to the care partner over here. And so to be able to have this like permission and process to bring them together was profound. And then I think the last thing I would say about that a mentor told me was just kind of this validation that if it feels complicated, you're probably on the right track because this is a complicated area of practice.
Mhm. Yeah.
Yeah.
Yeah. I talk about from what I do, I do a brain tune up. So we talk, when I evaluate someone and come back with recommendations after the workup, like there's many, many things on that list that could be optimized for that individual and that family. And that sounds like the same as what you do. And you don't know usually like what percent of the challenges are caused by one specific thing, but they all are connected.
Yes.
If someone wants to work with an occupational therapist for themselves or a family member, especially specifically who's dealing with Alzheimer's or related diseases, how would they find out about that?
Yeah, that's a great question. So, Sarah Lyon with OT Potential has started a platform to really be able to search, no matter where you are, occupational therapists either in your state or that specialize in the area that you want to be served. I find that as at least the quickest place to get, especially to folks who are trained in what you want to be served with. The Dementia Collaborative also has a search specifically for those who've been trained in dementia or dementia program of skills to care. It certainly doesn't hurt to whatever community you're in. You may be the voice that brings an OT and like helps that OT raise up into a role that's needed, but maybe isn't there yet. So I also wouldn't hesitate, no matter where you are, if you're like, there's no OTs in our community that do this. If you can even find one or like start with the providers you're already seeing to be like, do you know an OT locally? Or you could state associations. Every state has I'm mostly confident. I don't actually know that as a fact, but most states have a state association of occupational therapists that also would immediately put you in touch with your local group of occupational therapists. You could always reach out to the national one too, the American Occupational Therapy Association. And if you're in other countries listening to this, there are OTs who I feel like are kind of paving the way in some other countries too, with even these evidence-based programs. I think Canada, we've got some in Italy, I wanna say Brazil.
It's not surprising, frankly, because there are a lot of other countries that do holistic person centered care much better than the US does. So, not surprising.
Well, and it makes me curious too of like, if you could, um, just I'll give the quick context, which is that I came into knowing you and like one of my first touch points with you was you were presenting at a conference and you mentioned the value, of providing referrals to, I think it was PT and OT. And it was really appreciated hearing you say that. And then, it makes me wonder what be helpful as time moves forward. Like, what do you think OTs should know about kind of coming into the community of neurologists that could be helpful to know from the viewpoint of a neurologist?
More collaboration and honest, open conversation between disciplines is certainly needed. Absolutely. And just to echo what you were saying, that my philosophy has always been there's so much we can do to help individuals who are experiencing this progressive memory loss, Alzheimer's, and related diseases, and there's so many willing and able and excellent providers and clinicians out there like you. Can't do it alone. So I'm glad. Yeah. So lucky. I'm so glad I mentioned that point in front of you that day. And here we are years later.
True story.
I know you are in improv comedy, and it's improv is something that we bring up in working with people with these diseases, especially for care partners, to help them change their thinking about the reality in the world that their person is living and how to better interact and go with the flow. So yeah, I'd love to hear about how you got into that, has that changed or informed at all now your how you work with people?
Oh, tremendously. And I've really actually it's kind of funny too the way some of that improv has evolved because the work of Oakwood really let me experience and also identify that that was the strategy that was being used in communication. So I think in the traditional medical models of learning, I had never come across that, or at least not worded in a way that it was so digestible. And so it really was first in my work with Oakwood that I really got to watch it. It was actually in a TEDx talk that Jessica had shown us, and then really just Oakwood does such a great job of integrating it into all that they do. And they're a nonprofit in Mesa, Arizona. But what hit home to me about improv, and once I started using it, it's like getting in the river. You know what I mean? You're like, oh, you're not going to fight the flow once you've experienced the improv. But the thing I find about it, and for those who maybe want like a long story short on what I'm talking about, it's really using the principles of improv comedy. Yes, and. So, if someone says that, like, you're flying to the moon tomorrow, it's like, yes, and I'm not sure what I'm gonna wear, but, like, I'm on that flight. And so there's no resistance in whatever is said, no matter how wild it sounds. But I think one of the things that I've loved about it is it keeps me so present because it's like I can't keep up improv with the clients if I'm lost, if I'm not right there in that moment. I will say that that has been something that it tends to be easier to or that it often needs a layer of demonstration
Yeah.
to be able to be like, "Oh, that's what you mean." And I've come to learn too that there's an impact and a layer of roles that I don't have, that I even tell caregivers where I'm like or care partners where I'm like, "Y'all have, like, 60 years of roles that you've kept," when you communicate that, like, I don't have. So, when she's like, "Get out of here," I'm like, "No problem." Whereas he's maybe used to being like, "No, I'm staying because you need me to." So, does that kind of answer the question?
Yeah. So you got connected to a local improv comedy group
And
and do some things with them. And
so in Mesa, there's a place called the Neighborhood Comedy Theater, and they reached out to me a couple years ago and actually asked me to be one of their storytellers. So I haven't actually done any shows with
okay.
them. I
Yeah.
haven't to do any of the actual improv on stage, but I do go and offer them stories that they then take and twist into
Yeah.
very funny skits.
And just to see that what happens and with the story that you presented is really amazing.
It's entertaining
And
for sure.
makes our work so much more, frankly, fun.
Yeah.
And it's not in a demeaning way when you're going along in yes anding, because there's always the two or more realities for the person with Alzheimer's too. They fluctuate and they're not, there's a grounding in the reality of the where we all are connected. I'm going off here, but I think you know what I mean.
Yes. And I also, in case anyone also just like maybe misunderstood what I was just saying too, the entertaining piece is improv in a neighborhood comedy theater.
Yeah.
So, you know, just to be
Not
mindful of like the
direct patient care. Absolutely.
and something that I think is also interesting is that a profound intersection for me was also in learning and really seeing that the social skills of someone are not always equal to what we would stereotype as their cognitive skills. So over time, and this is part of the assessment that I do, is really seeing how someone interacts with me. Do they recognize if I put my hand out? Do they recognize I'm putting my hand out? Do they shake it? Are they oriented to the day? Can they say their first and last name? And and these, though there's so many overlapping skills with social skills, right? But I think there's something also that the improv invites that's such a big net, if you will, in regards to folks who are able to speak maybe one word or maybe can just motion things at you, that the improv works as well with nonverbals than it does.
Mm,
That it's like if someone's handing me something, that I could say, "Oh, thank you. I thought I lost it." All that's just someone handing me something. So
that's
I'll
beautiful. Yeah. Wow. We certainly could spend a whole other segment and many more with you giving more specific, concrete advice, how to's for care partners, like what you do on the ground floor with your clients and patients and families. So I just want to acknowledge that we were talking at more of a higher level philosophical today. And I hope that I want to encourage, especially care partners, to seek out these services and support. There's so much out there. It can be hard to find and navigate. And so if people want to find you, Monika, how can they find you and what you're up to?
Yeah. So the best place really is LinkedIn as well as OT Potential. So you can find my information in both of those spaces. And I really do want to validate what you're saying and encourage people to recognize that you as care partners are some of like the most forward reaching innovators. And a part of me like hates that's like one more thing on your shoulders in the midst of showing up for your loved one. And don't underestimate that you saying something or you asking for an OT in your community to be trained in a program, it really may be the beginning of something. So please don't be discouraged if they're not there yet. We're at such a point of like charting the way. The grass is not yet flat in these areas. So just want to toss that out too.
Thank you. Absolutely. There's so much more openness and momentum to these services growing. So advocate for yourselves and your loved ones. And I'm sure other people in your community need it also. So get the ball rolling. Excellent. Well, let's wrap up. Any final words of wisdom for us, Monika?
Man, I think it's like trying to just keep it simple and surround yourself with good people to know that we're not alone. My hope is that every year, anyone who's encountering cognitive changes can find an OT in their area to like get yearly assessments. So my hope is that, yeah, the systems can just keep braiding together or like you said, talking at least. I think that sometimes, and I know you've certainly inspired this for me too, is like there's not necessarily answers that we're going to have in conversations and to not shy away from conversations just because we don't have answers, but to feel empowered to come with questions. And that's enough. Yeah. And thank you. Thanks for the work that you're doing and for continuing to hold space for things that are unfiltered.
Yay. Love that. All right. Well, thank you everyone for joining us today in this great conversation. If you're watching on YouTube, please like and subscribe to our channel, comment. If you're listening on the Apple or Spotify podcast platforms, please rate and review. We'd love to hear from you. If you want to learn more about me and about the Brain Love practice, check us out at mybrainlove.com, all one word, or please always feel free to email us at Dr. Cabral at mybrainlove.com. That's Dr. Cabral. All right, everyone, have an amazing, resilient day.